Thyroid hormone assessment is essential for evaluation for a number of clinical disorders. So children who are not growing well, who have issues in terms of development, in terms of bowel movement not doing well, overall thyroid hormone deficiency is suspected, and in those scenarios thyroid assessment should be done to look for features of deficiency of thyroid. Individuals who have increased heart rate, palpitations, sweating, weight loss, in all those scenarios thyroid excess is likely. The three major hormones which are looked at in terms of assessment of the thyroid gland is the T3 and T4, which are produced by the thyroid, and TSH, which is produced by the pituitary. The TSH produced by the pituitary controls the secretion of T4, which is then converted into the active hormone T3, and assessment of all these three hormones provides us information about how the thyroid gland is functioning. The thyroid hormone does show a reasonable amount of diurnal variation, but for TSH they are not significant. So if you want to measure TSH levels, we can measure TSH at any time of the day. T4 levels are affected by the timing of the dose that we have taken. So in individuals with hypothyroidism, if we want to measure T4 or a free T4 level, we should do it before the medicine is given, otherwise the levels will be falsely high. In individuals who have low level of thyroid or hypothyroidism because of problems in the thyroid gland, the first change which happens is increase in TSH level, and this TSH tries to compensate this deficiency by increasing the level of thyroid hormone. This is followed by deficiency in the T4 levels, which levels become low, and finally there is a reduction in terms of the T3 level. So the most important and the first investigation to go up is somebody who has got a primary hypothyroidism or a problem in the thyroid gland is the TSH, followed by T4. T3 is the last test to go down, and body tries to compensate to avoid the T3 from falling down, so it has got a very limited role in terms of evaluation of primary hypothyroidism. In a subset of individuals, approximately 1 to 5% who have a problem in the hypothalamus or the pituitary, which we call as central hypothyroidism, there is a normal level of TSH or a low level of TSH in the setting of low free T4. If we have a low free T4 and a normal or low TSH, it indicates that the problem is not in the thyroid but in the pituitary, and there are implications in terms of need for evaluation of other anterior pituitary hormones like adrenal hormones, like growth hormone, like hormones which regulate the gonadotropin secretion, along with an MRI head. Individuals who have high levels of thyroid because of the increased production of thyroid hormone, this is what is known as hyperthyroidism or thyrotoxicosis, have a high level of free T4 and T3 with a low level of TSH. In this scenario, again, the first test which is important in that regards is a low TSH, followed by an elevated level of T4 and T3. So in individuals where we are suspecting a hypothyroidism or deficiency of thyroid, we should go for free T4 and TSH. While individuals where we are suspecting a high level of thyroids, we should look at both T3, T4 and TSH. A large proportion of thyroid hormones circulate in the circulation bound to the thyroxine binding globulin, and only around 0.1 to 0.3% are free. It is only these free forms of thyroid which are responsible for its action. So therefore, when we are assessing individuals for thyroid disorder, it's always better to look at the free hormones rather than the total hormones. Conditions which are associated with increase or decrease of thyroxine binding globulin, the protein which binds to the thyroid, are associated with abnormal interpretation of thyroid hormones because of problems with the TBG levels. So individuals who have pregnancy or who are exposed to large amount of estrogen will have a high level of thyroxine binding globulin, falsely increasing the T4 level, and in this scenario free T4 would be a better marker. Individuals with low levels of proteins because of a liver disease or loss of protein in the urine in the setting of nephrotic syndrome will have a low level of thyroxine binding globulin, resulting in a low level of total hormones while the actual free hormones are normal. This makes the evaluation of free hormones essential. Regular monitoring of thyroid functions are essential in individuals who have thyroid disorders, whether it is hypothyroidism or hyperthyroidism. In individuals who have primary hypothyroidism, wherein a problem is in the thyroid gland, we need to mainly try to focus on the TSH levels. The hormone level should be done approximately 6 to 8 weeks after the initiation or treatment or adjustment of dose, and 3 to 6 monthly if the dose has been stable. TSH hormones should be made a normal range, typically between 0.4 to 4 milli-international unit per liter in cases of primary hypothyroidism. In individuals who have problems in the hypothalamus or pituitary, that is the central hypothyroidism, there is no role of monitoring TSH, and there we want to maintain the free hormone, the free T4, in the high end of normal level. In individuals who have thyrotoxicosis or hyperthyroidism, wherein the thyroid hormone levels are high, we should monitor T3, T4 and TSH and maintain them in the normal range. High levels of T3 and T4 with low levels of TSH means that we need to increase the treatment dose, while those who have a low level of T3 and T4 and high level of TSH suggest that we are giving too high dose, which needs to be reduced.